Okay guys, today we will be discussing about the chest leads. In chest leads you have to know 3 points. One is the placement of the chest leads, how they are oriented to the heart, and what are the waves which we get in V1 and V6. First let's talk about the placement of the chest leads. This is the fourth rib, fourth intercostal space, fifth rib and fifth intercostal space. V1 or first chest lead is kept immediately right to the sternum in the fourth intercostal space. V2 is immediately to the left in the fourth intercostal space to the sternum. V4 is kept in the fifth intercostal space on the mid clavicular line. V3 is kept at the midpoint of V2 and V4, exactly at the midpoint of V2 and V4. V5 is kept in the fifth intercostal space in the anterior axillary line. And finally, sixth chest lead is kept in the mid axillary line in the fifth intercostal space. Now that we have seen the placements of these chest leads, let's see how these chest leads looks the heart. This is the cross section of the heart. This is the right ventricle, this is the left ventricle, and this is the septum. V1 and V2 are also called as right ventricular leads or septal leads because they see the septum the most. V3 and V4 are called as anterior leads because they see the anterior wall of the left ventricle most. And V5 and V6 are called as lateral leads because they see the lateral wall of the left ventricle most. For example, if a person is having anterior wall MI, then which leads you will be seeing? That is V3 and V4. If he is having lateral wall MI, V5 and V6. If he is having septal MI or right ventricular MI, you will see V1 and V2. If a person is having anterolateral MI, V3, V4, V5, V6 will be deranged. In this way, you have to understand the position of these leads and how they looks the cross section of the heart to know the pathology like myocardial infarction and which part of the heart is affected in that myocardial infarction. Before going further, I want you to remember a very important difference between a limb bleed and chest lead. When you take a limb bleed, we know that both right ventricle and left ventricle undergoes depolarization simultaneously, right? When these both undergoes depolarization at a time, this limb lead will add both these vectors and it will represent a mean vector. But when we come to a chest lead, it will pick up the depolarization which is nearer to it and then it will pick up the opposite chamber separately. For example, if we take V1, it will represent first right ventricular depolarization and then separately it will represent left ventricular depolarization. And it will pick up first right atrial depolarization and then left atrial depolarization. By this, we can separate the right atrial pathologies and left atrial pathologies and we can identify them easily. Let's see how this happens. First, take V1. V1 is here. The axis of V1 is from Wilson central terminal or virtual electrode which is present in the center of the heart to this one. This is the V1 or exploring electrode. First, right atrium undergoes depolarization. Positive is coming almost towards the positive. So we will get a positive right atrial depolarization wave. This is the left atrial depolarization. Left atrium depolarization, positive wave going away from the positive. So we will get a negative left atrial depolarization wave. So we will get a biphasic P wave in V1 lead. And then what happens? AV nodal delay. Due to this AV nodal delay, we will have an isoelectric line. And then septum undergoes depolarization. And this is the septal depolarization wave. So positive going towards the positive, we will get a positive wave. And then when it comes to right ventricle and left ventricle, first it will pick up right ventricle. When it picks up right ventricle, we will get another positive wave. And both the septal depolarization wave and the right ventricular depolarization wave constitutes the R wave in the V1 chest lead. And then left ventricular depolarization. Left ventricle is very much thicker than right ventricle, right? And positive wave going away from the positive electrode. So we will get a huge negative wave in V1. And this negative wave is also called as S wave. And the amount of current in the LV will determine the depth of the S wave. When LV currents are more, for example in left ventricular hypertrophy, this negative wave will be more deeper. And finally the T wave. When we come to the V6, V6 is here. This is the axis of the V6. Atrial depolarization of right atrium, left atrium, septal depolarization, right ventricular depolarization, left ventricular depolarization. Both first P wave is atrial depolarization. This V6 will first picks up the left atrium and then the right atrium. So first it will pick up the left atrium and right atrium simultaneously, because right atrium and left atrium are almost together positive waves traveling towards the positive electrode. So first part will be left atrium and then the right atrial depolarization and then AV nodal delay, isoelectric line, and then what happens? Septal depolarization, positive wave going away from the positive wave going away from the positive electrode. So we will get a negative wave, negative Q wave. This is due to the septal depolarization, and then it will pick up only left ventricular depolarization. So when it picks up first left ventricular depolarization, we will get a tall R wave. This tall R wave is a characteristic of V6, and then negative S wave. This negative S wave is due to right ventricular depolarization wave, positive wave going away from the positive electrode, and finally T wave. What is the most important characteristic in V6 is tall R waves. This wave is almost similar to lead 2 wave, but what is the main important difference is tall R waves, because here only left ventricular depolarization is recorded separately. If we take mean of left ventricle and right ventricle, which is done by the limb leads, the magnitude will be decreased. But when we record the left ventricle separately, we will get a very tall R wave in V6. So what are the important points in V1 is biphasic P wave, negative S wave, tall negative S wave or deep negative S wave, and what are the important points in V6 is tall R wave. And the right atrial hypertrophy, we can identify it by V1. How? If the initial part is increased, then it is right atrial hypertrophy, and this part is increased, then it is left atrial hypertrophy. Left ventricular hypertrophy, if the depth of the S wave is increased, then it becomes the left ventricular hypertrophy. We will discuss about these pathologies separately, but first appreciate how these leads are important to identify the right part pathologies and left atrium and left ventricular part pathologies separately. Thank you.